Assalamu alaikum wa rahmatullahi wa barakatuh. So today we will be starting with trauma. And in the trauma, we will start with the upper limb, shoulder, and the upper arm injuries. We will start with the clavicle. And as you all know by anatomy, you can see here the scapula, and it's articulating with the clavicle. So the joint is called Acromioclavicular Joint, and we have some ligaments here in the Coracoclavicular ligaments. Two ligaments, trapezoid and conoid. So usually the clavicle is broken either by direct trauma or by falls. Usually the displacement of the fracture or the deforming forces are the arm, because it's pulling down, your weight of the arm is pulling down, and you have the other part, the proximal part, is being pulled by the sternocleidomastoid muscle. So if we're going to classify the clavicular fracture according to Allman, he says that it's three groups, 1, 2, and 3. 1 is the middle, which is the most common, 80%. Group 2, which is the lateral or the distal, 15%, and group 3, which is the proximal, 5%. Group 1 and 3, usually they are treated conservatively. They may need surgery, and we will talk about it in a bit, but usually they are conservative. Group 2, which is the distal, are subdivided according to the coracoclavicular ligaments that I showed you in a bit. Group 2, subclassified. So what's the subclassification of group 2? Either it's intact CC ligament, which is coracoclavicular ligament, torn conoid, but the trapezius or trapezoid is intact, articular fracture C. So clinical features of broken clavicle, the arm is usually clasped to the chest. This is how the patient is coming to the emergency room. You can feel the subcutaneous lump. On the lateral fragment is pulled down by the weight of the arm, the proximal or the medial by the sternocleidomastoid. So if you do an X-ray, you can see this is a fracture here. This is the clavicle. Okay, this is the acromioclavicular joint and the coracoclavicular. This is a fracture here in the distal 1/3. This is another fracture in the clavicle. It's in the middle 1/3. It's angulated a bit. Okay, it's not displaced. So this fracture can be treated conservatively, for example. In this X-ray, you can find here that there is much displacement. The proximal part here, the medial part, is going upward. The lateral is going downward. And on the skin, you can see this sign that the fracture of the clavicle is obvious, and you can feel it. And sometimes it's called tenting of the skin. So tenting of the skin, it is an impending open fracture. So if you leave the patient on tenting skin, the clavicle will make it an open fracture. That's an indication for surgery. For treatment, close reduction, okay, and arm sling. Then after 2 weeks, you start to do exercises. Sometimes you have to do internal fixation. So how or what are the prerequisites for internal fixation? Most important one is displacement. If the fracture is very much displaced and it's not being reduced by close reduction, you have to go for internal fixation sometimes. If we go to the scapula, scapula is an irregular bone, and you can see here from the posterior part, this is the spine of the scapula. The superior part, it's called the supraspinatus, and you can find the supraspinatus muscle there. Here, the infraspinatus fossa, and you can find the infraspinatus muscle. From the anterior, this is the subscapular fossa, and you can find the subscapularis, which are the rotator cuff muscles of the shoulder. This is the articular surface of the shoulder, which is the glenoid, the acromion, and the coracoid. From the lateral aspect, you can see the glenoid, where the shoulder articulates, the proximal humerus are the glenoid. This is the coracoid, and this is the acromion. Usually, scapular fracture leads or give you a hint that this is a high energy trauma. You have to be careful with this patient, and at the time, ATLS, ABCD, ABCDE. Save the life, then look for the fracture. So he might have a flail chest, which is fractures in more than 2 ribs on the same side, 2 fractures in the same rib. So more than 2 ribs, so mean 3 or more, two sides fracture in the same side of the chest, it will give you a piece of the chest wall, so the air will push it inside, and there will be paradoxical chest wall movement, hemothorax and pneumothorax, and some injuries to the great vessels. It's very important, I will go back to the picture. If there is a fracture involving the scapula, you should make sure that it is not involving the glenoid, this part, the glenoid, because the glenoid is an articular surface. And as you remember from the fracture lecture, if there is a fracture which is intra-articular, we have to get it back reduction by anatomical reduction, and the fixation should be rigid. Okay, another time, intra-articular fracture, anatomical reduction, and rigid fixation. By X-ray, sometimes it's really difficult to see the scapular fracture because, you know, there's a lot of tissue around it. You have to do sometimes CT scan to know that there is no intra-articular involvement in the glenoid. For example, this is an X-ray showing a fracture just inferior to the glenoid. For the treatment, you don't have to do reduction usually, but if it's involving the glenoid more than 25%, and if there is dislocation, you have to go for open reduction and internal fixation because you want to achieve anatomical reduction, and you have to put plates, screws, so whatever. Scapulothoracic dissociation. You know that the scapulothoracic joint moves usually when you are abducting your arm. So the last few degrees from your shoulder movement is doing by the scapulothoracic joint. Dissociation usually is diagnosed by X-ray. The treatment usually resuscitation because it's a high energy trauma. You may have another injuries, and that's it. Acromioclavicular joint. This is the acromion, this is the clavicular. So acromioclavicular joint, it might get disrupted, and this is the classification of it. So usually the injury is happening due to falling down, direct trauma, and it might sublux the clavicle. In more severe injuries, the coracoclavicular joint might be involved. So I'm going back. This is the acromioclavicular ligament. It might be torn. In the more severe cases, the coracoclavicular ligaments might be disrupted, the conoid and the trapezoid. There are six types of this ligaments injury. Either it's a sprain, like this type, it's only the sprain, as you can see in here. The second type, torn AC ligament, but the clavicle is a little bit raised. The CC still intact, like this. In the third picture, you can see the acromioclavicular is disrupted, but the conoid trapezoid are still intact. Type 3, both AC and CC ligaments are torn, as you can see in this picture. There are some types which are rare. If you have posterior clavicle displacement, the clavicle is displaced upward or inferiorly downward. So these are the 6 types of AC joint injuries. This is a picture, you can see it in here clinically. You can see a step on the acromioclavicular joint. On X-ray, you can see a distance between the clavicle and the acromion. What is stress review? You let the patient hold 5 kilograms on the affected hand, and you take an X-ray, you will see marked displacement in comparison to the contralateral side. So if there is more than 50% difference, this is a positive test. In treatment, usually in sprains and subluxation, only sling, and then you can do exercises. In dislocations, we have to go and operate. We repair sometimes the ligament, and if it's delayed, we can do reconstruction, we can put screws, and these are the modalities of treatment. For the complications, you may have something called rotator cuff syndrome. So you have to know the anatomy of the rotator cuff muscles. The most important one of them is the supraspinatus. And because the supraspinatus is going through the subacromion space, so you can see the acromion, and below the acromion, there is the supraspinatus. So when you have a dislocation or trauma there, you might get supraspinatus tendinitis, which is pain, and you have to evaluate your patient for that. Usually we give them non-steroidal anti-inflammatory drugs. If it did not get well, sometimes we can give them injection, and in the last stages we can go for surgery. If it's unreduced, you can go to fix it and do reconstruction of the ligaments. Sometimes you may get ossification of the ligaments. Ossification means pain. So painkillers, physiotherapy, and secondary osteoarthritis for sure. For the sternoclavicular dislocation, either it's anterior or posterior. Anterior, you can see it, it's less harmful. Posterior, sometimes it's worse because you can compress on the trachea and the major vessels. So you can confirm it by CT scan, as you can see on this CT. You can see it's posteriorly dislocated inside the thorax. Treatment, if it's anterior, you have to do reduction. Sometimes you may give your patient anesthesia because it's really painful. Posterior dislocation, you have to reduce it also. If it fails, medial end of the clavicle is grasped with a bone forceps. For sure, this is under general anesthesia. So you go, it's from simple to more complicated and more invasive. And after that, you can put your patient on the figure of 8 bandage, as you can see in this picture. Dislocation of the shoulder, very, very, very important and very common. So there are some precipitating factors, risk factors, like the shallow glenoid, the shallow socket, okay, extraordinary range of motion, like the sports injuries, like sport people, athletes, stress activities, and ligaments laxity and or glenoid dysplasia. So ligaments laxity is very common, sports injury or trauma is very common, and shallow glenoid. So this is the glenoid, this is the labrum around the glenoid that will make the negative pressure inside the joint, increase the stability, and this is the biceps, the long head of the biceps tendon is attached to the superior glenoid. Anterior shoulder dislocation, which is the most common type of dislocation. It's either anterior, posterior, inferior. The most common is anterior. It's usually by falling on outstretched hand backwards. It will give you the presentation of the patient in the emergency room, abduction and external rotation. It may cause severe pain. It may be associated with a neurovascular injury, mainly the axillary artery or nerve. And on X-ray, you can see that there is empty glenoid. This is the glenoid, and this is the humeral head. The humeral head should be in here. So it's dislocated anteriorly and inferiorly. So this is an empty glenoid at that time. Treatment, for sure. Any dislocated joint, you have to reduce. Any dislocated joint, you have to reduce. So reduction with any maneuver. Okay, you may give your patient sedation or even under general anesthesia. Then you put him for a sling 1 to 2 weeks, and then you start exercising. A lot of method. You have Stimson's method. It's like you can see in this picture. The patient is lying prone, and his shoulder or the weight of the arm by the gravity is pulling the shoulder. The second one is Hippocrate, which is a bit invasive, as you can see in the picture. And the last one is Kocher. So Kocher, usually I use it in the emergency room. No traction is applied. You just flex the elbow and make it as a rotation. Okay, so you hold the elbow, flex 90 degrees and slowly rotate it. Okay, lateral rotation or external rotation. Then you do abduction and internal rotation. For posterior dislocation, it's not so common as the anterior because posterior dislocation usually needs either direct blow from the anterior part, epilepsy, electrical shock, and the arm might be locked in internal rotation position. So for posterior dislocation, you have to get an X-ray to make sure, and usually you can see a pathognomic sign, which is light bulb sign. So if you can see on your left side in here, you can see this light bulb sign. Treatment. So treatment is reduction. Treatment is a reduction. This is the most important thing you have to know. What about recurrent dislocation? It's very, very common that a patient has an episode of shoulder dislocation. The problem is sometimes he might be having recurrent dislocation, more and more and more dislocation. Then he will have some complications for the ligaments, the labrum, and the bone. So clinically, the patient usually knows the position that the shoulder will be dislocated. And our test for them is called the apprehension test, which is abduction and external rotation, the patient will be afraid that the shoulder will be dislocated. Then we do something called the relocation test. We push on the shoulder and the fear for the patient goes away. So we will talk later about shoulder examination, but this is just an idea. And you can see on X-ray something called the Hill-Sachs lesion and the Bankert lesion. Bankert and Hill-Sachs. What are the Hill-Sachs and Bankert? Because of the recurrent dislocation, the bone and the labrum is getting injury. And you can see it on X-ray in here. This is called the Hill-Sachs lesion on the posterior superior on the humeral head. And on CT scan, you can see the Bankert lesion. Okay, you can see here the Bankert lesion, and this is the Hill-Sachs. Anterior, inferior, superior, posterior for the Hill-Sachs, and anterior, inferior for the Bankert. This was very fast, the shoulder dislocation. What about the proximal humerus fractures? For the proximal humerus, it's common in osteoporotic bone usually, and usually for women, present usually with pain, bruising like any other fracture, unable to move. The classification for the shoulder fracture, proximal humerus fracture, is called Neer's classification, and Neer depended on how many parts are in the fracture. So one part, which is undisplaced fracture, two parts, usually the neck fracture, three or more. So this is comminuted fracture with the tuberosities. So we have the articular surface, greater tuberosity, lesser tuberosity, and the shaft. So if there is one part, the treatment usually is arm sling, two parts, close reduction, and you might need to do fixation or splint. Three parts and more usually needs open reduction and internal fixation because the reduction is unacceptable usually. Check for the axillary nerve and the brachial plexus, very important. You can see here in this picture the hematoma in here. You can see in the subcutaneous tissue, a lot of blood. Don't worry, it will heal soon. This is the classification of Neer. You can see this is one part, two part, three part, four part. So this is two parts fracture, which is the articular surface and the neck. Three parts, the articular surface, greater tuberosity, and the shaft. Four parts, greater tuberosity, lesser tuberosity, articular surface, and the shaft. So the more you go with the classification, the more it's getting more complex. But Neer did not consider any piece as a part unless it was displaced more than 1 centimeter and it was 45-degree angulated. So to consider a part, we have to have these two prerequisites. Okay, after finishing the proximal humerus, let's go to the midshaft or the diaphyseal fractures. So in the proximal part, there is the epiphysis, which is intra-articular fractures. You have to get anatomical reduction and rigid fixation. In the shaft in here, in the diaphyseal fractures, extra-articular. So we may need functional reduction and relative stability. So usually it's caused by falling down, direct trauma, pain, bruising, swelling. Be careful for the neurovascular examination, and the most important thing to examine in the humerus fracture is the radial nerve, which is doing extension for the wrist and the metacarpopharyngeal joint, okay? So please keep this in mind, it's very important. Treatment, fracture of the humerus usually heals very good, and the humerus was named as the forgiving bone because whatever you do with the humerus, mostly it can accommodate the displacement, it can accommodate the mal reduction. So usually more than 90% it heals without surgery. If it did not, you have to go and fix either by plate, like in here, nail, or external fixator. And each one of these has a special, what do you say? So each one of these tools, they have special considerations, and the patient has to have like specific situations. For the distal humerus, we have three types because we are coming down to the elbow, getting close to the articular surface. We have three types, either extra-articular, which is mostly supracondylar, intra-articular. In the intra-articular, it's two parts, either one of the condyles, medial or lateral, or bicondylar. So for the supracondylar, as you remember from the pediatric age group, it's very common the pediatric age group, not in the adults. Usually in the adults, if you have high energy trauma, there will be comminuted fracture in the elbow, and usually it needs open reduction internal fixation. This is a X-ray for a supracondylar fracture, as you can see in here. For the condylar fractures, except for example, in the osteoporotic, they may get fractures very easy, but in young people, they need to have high energy blow or trauma. Okay, this is the humerus, this is the ulna, this is the radius, this is the supracondylar region in here, this is the medial condyle, this is the lateral condyle. As you can see in this X-ray, we have a fracture involving the articular surface and both condyles. So what's the treatment? If the joint is not displaced, so the fracture is extra-articular, just posterior slab with 90-degree flexion, wait 4 to 6 weeks. If the joint is displaced, so it's intra-articular fracture, anatomical reduction, and rigid fixation. So you have to go for open reduction and internal fixation. Fracture usually heals within 8 weeks. The problem is that you get stiffness very easy in the elbow. That's why when we go for internal fixation, we start to do movements after 3 to 4 weeks. This is an X-ray showing a fracture in here. You see the fracture line, and this is after fixation of it. Fracture of the capitulum, usually it's for the adults. It's not for the pediatric age group. So from falling on straight elbow, on X-ray, it's very easy. You can see here the capitulum, it's fractured. And because the capitulum is intra-articular, because it's articulating with the radial head, so this is the radial head, this is the capitulum, they are articulating together, anatomical reduction and rigid fixation. Dislocation of the elbow is the second most joint to be dislocated. In adult, it is the most common. The second most common. In children, is the first most common. The elbow is very stable usually, and after dislocation, you have for sure, as I told you before, you have to reduce. 90% of the dislocation is posteriorly or posterior lateral. If it's without fracture, reduce, hold, everything hopefully it's gonna be fine. This is an X-ray. So closed reduction under general anesthesia, check for nerve function and the circulation, and collar and cuff. Then you can remove the cast after 1 week and keep the patient for 3 weeks on collar and cuff. This is the collar and cuff that you keep the patient in for 3 weeks. If isolated radial head dislocation, usually it's rare, associated with ulnar fracture. We will talk about it more in the next lecture. Any deformity of the ulna that may prevent full reduction, so you have to go fix the ulna, then reduce the radius. So the ulna may be a problem for the radius to get reduced. This is a picture showing the swelling of the elbow on the lateral side. This is a X-ray. You can see here the radial head, it's anteriorly to the capitulum, so it is dislocated. For the proximal end of the radius, it's very common in children and young adults. So it's falling on outstretched hand with the elbow extended, and the forearm usually is pronated. In the adult, what will happen is fracture of the radial head fracture. In the pediatrics, because it's cartilaginous and it's more strong, there will be neck of the radius fracture. Increasing in pain during pronation and supination because the radius is rotating. So if there is a fracture and it's rotating, it's going to be more painful. This is an X-ray showing the fracture of the radial head. And there is a classification for radial head fractures. It's called Mason classification. Type 1 non-displaced, type 2 partially displaced or in the neck, type 3 comminuted, type 4 there is dislocation of the elbow. So in treatment, non-displaced, back slab, displaced, intra-articular fracture, open reduction, internal fixation, anatomical reduction, and rigid fixation. For children, look at this. Children, if the radial neck fracture was less than 30 degrees, so it's acceptable. That's what I've told you before, that if you have a pediatric age group and they had some tilting or angulation, sometimes it's acceptable, as in here. So 30 degrees is acceptable, and 3 millimeter transverse displacement is acceptable. That's why just conservative management. If it's more, open reduction, internal fixation. Now for the olecranon, you know the olecranon, you have the triceps muscles coming down from the arm and holding the tip of the triceps. So the mechanism of injury, it's either an avulsion fracture or direct blow to the olecranon. In the kids, usually it's rarely broken because the supracondylar area is much weaker. So the supracondylar fracture will happen in pediatrics. So if it's comminuted, there are two types, comminuted or transverse fracture. This is a clean transverse fracture, and this is a comminuted one. So you can see that there is bruises. You can feel on the physical examination the gap of the olecranon, and on the lateral X-ray you can diagnose it. Comminuted fracture, what to do? Usually, if it's not much displaced, you can put the patient on arm sling, then active motion. Undisplaced, immobilization. If it's displaced, you can do open reduction and internal fixation by a tension band like screw or plate. So this is a fracture, this is a plate was put in, or a tension band. So the idea of the tension band, that it converts the traction into compression. So when the triceps is activated, the triceps from here will pull the vector on upward. The tension band will change this tension into compression on the fracture side. That's the idea of the tension band. So this was just the first part of the upper limb. In the next lecture, we will be talking about the second part, which is the part 2 upper limb.